Good afternoon, dear participant, and welcome to the HIV/AIDS National Distance Learning Seminar Series. Today's topic is Growth and Development Assessment of Children Living with HIV. Today we have Dr. Rema Chandramohan with us. We welcome you, ma'am. Dr. Rema Chandramohan, PhD, is a pediatric professor at Pediatric Institute of Child Health, Chennai. She completed her MBBS from Madras Medical College and MD in Pediatrics from Institute of Child Health, Madras Medical College. She did postgraduate diploma in development neurology in 2012. After starting her career in rural services, she served as an assistant professor in the Department of Pediatric and Neonatology, Government of KGH and MMC from 1998 to 2001 and Department of Neonatology, MMC and ICH from 2001 to 2008. Dr. Rema has teaching experience of more than 16 years in neonatology. She is trained in developmental pediatric with prefect skills DAS 2nd in Pune and ballet 3rd. She has done international observerships in neonatology from Alice Spring Hospital, Australia in May 2000, University Hospital North Staffordshire, UK in May 2004, and St. Mary's Hospital, Manchester, UK in May 2004. She is a life member of many pediatrics firms, delivered lectures on neonatology and developmental pediatrics, and presented many papers in national and international forums. She was awarded for Outstanding Women Achiever at Dr. MGR Medical University, Tamil Nadu. Thank you, ma'am, for accepting our NDLS session. Please take over the session.
Good afternoon to all of you who have keyed in and are going to listen to the next 1 hour of the lecture. Although my topic is mainly meant for pediatricians, I am going to make it as simple as possible so that the other people involved in management of HIV children will also benefit from this session. I am not going to only talk about picking up developmental delay in children living with HIV, but in general how to look out for a developmental delay and how to not only pick up, what to be done in case of a developmental delay. Those are going to be the objectives of my presentation today. So let me start with the first slide. So what does one mean by a developmental delay? So whenever there is a significant lag, although I have said physical, cognitive, behavioral, emotional or social development, to make it simple, the different domains of development of a child, which includes gross motor functions, fine motor functions, social adaptation, language, whenever there is a delay in any of these domains in comparison with the normal children of that particular age, any significant lag, that means it should be a permanent lag before we call it a developmental delay. When you consider developmental disabilities, then we mean a group of chronic conditions which are severe in nature and which are due to mental and or physical impairments. And people with developmental disabilities will have problems with major life activities like language, ambulation, academics, and activities of daily living. So this can begin any time during the development, that is even from conception up to 22 years of age, when the brain development is totally complete and the disability can affect a person's lifetime work. Now there are several subtypes of developmental delay, out of which global developmental delay, when it involves more than 2 domains, occurs in 1 to 3% of the population. But developmental disabilities as a group is supposed to occur in 10 to 15% of the population among children. Intellectual impairment is another subtype. Gross motor delay with or without cerebral palsy is a third one. And specific learning disorders, autism spectrum disorder, primary sensory disorder, which can be a visual or an auditory handicap. So this can then be associated with speech and language disorders, and school related disorders can occur which are in the form of ADHD and LD. On looking at the prevalence of developmental disorders over the years, we find that the developmental disorders has increased from 13.87% to 17.1%. That is 1.8 million children are now found to have developmental disabilities. That could be because there's a greater awareness. Screening is much more stringently followed these days. The autism incidence has increased by around 300% and ADHD has also significantly increased to 33%. The only good thing in this is that the hearing loss incidence has significantly come down to about 31% because of the effective neonatal hearing screening programs which are in place and the use of hearing rehabilitation techniques. So having said this, now we know that any developmental delay is that a condition where a child does not match up to its peers in the different domains of development. Now, how do we pick up developmental delay? Can we just say that this child is delayed because he is not on par with his peers? Let's see. There are two ways of doing it. One is called a developmental monitoring or surveillance. Here we keep tracking a child's growth and development over time. So this can be done either by a general practitioner or anybody who comes in contact with the child throughout the child's early growth and development stage. So this person will continue to monitor the child's growth and development by following standard charts, and whenever there is any concern about the child's development, then they subject the child to a screening test. So what is a screening test then? So monitoring is, it's like a surveillance camera which is kept in most of these airports that we see. Here what does a camera do? It just records all that is happening in the radar which it is subjected to. But what does screening do? Screening is otherwise a frisking of a person to find out whether that person is really having a developmental delay. In this case we have to use a short and a standardized test. So you subject the child to a standardized test and then see if this child is really having a delay which you suspect the child to have. If the results of the screening test are cause for concern, supposing you find that even by screening this child is having a suspected developmental delay, then this child should be sent to a doctor who is a specialist in developmental problems or to a physician who can pick up if there is a medical cause for the delay. So now I am not sure how clearly you can see this chart, but these are very important guidelines which have been established by the American Academy of Pediatrics. Here they say that whenever a child comes for a well baby visit, maybe for an immunization or just for a checkup, you perform the surveillance. You perform the surveillance and find out if there are any risk factors which can predispose this child to a developmental disability. If it is there, then you subject the child to a screening test. If you find that this child in the screening test is having a developmental delay, then this child should be sent for further evaluation either to a developmental pediatrician or for medical evaluation to a physician. On the other hand, if the child does not have, what do I mean by risk factors? Say this child is born to, in this case, HIV positive parents, or this child has got a very bad neonatal period course or had antenatal problems. Any of those can come under high risk factors for developmental disability. Now you say that there is no risk factor for any developmental disability and this child has no problem in the screening tool also, then you can subsequently tell the parents to bring the child only at 9 months, 18 months and 30 months. Why does the child have to come if the child is normal at this stage is because so many developmental disorders are picked up later in a child's life, especially those which involve language, those which involve academic performance. So the child has to be under surveillance even after a period of 9 months, 18 months and 30 months. Only then, when you administer a screening tool and you find that there is no cause for concern, just an annual visit is enough. But if you find that again with the screening done at these prescribed times, if you find that there is a delay, then this child again has to be evaluated and screened for treatable conditions like maybe hypothyroidism or cardiac anomalies or malnutrition, things that can affect development. Okay, once you find that this child has been found to have a developmental disorder, then this child will require rehabilitation services. Now there are two kinds of screening. What is done by majority of the pediatricians is an informal screening, because we do not have time to use standardized tools which will require a little more time than just getting the history. So normally we do an informal screening where we just try to remember some milestones, and then we see if the child has acquired the milestones at that particular time. Starting from social smile at 2 months, we go on till about 3 years when the child starts dressing herself. I am not going into the details of this. This is available in most of the textbooks. Then we have something called red flag referral guidelines. This is from a university in Australia, which I had downloaded from the internet, and I found it quite useful because it has highlighted certain major milestones if missed can cause permanent disability later. If you see, the main one in red is lack of or limited eye contact, which will put the child at a risk for an autism spectrum disorder. So if this is there, this child has to be brought to the doctor. Now, in addition to that, if at any point you find that the child is not acquiring milestones at the time that the child should achieve, if the parents have strong concerns about the child's development, if the child is having any delay in acquisition of skills, if there is a loss of, if there is a difference in the tone in either side of the muscles, and if there is the child appears to be unduly floppy or unduly tense. So these are all the red flags which can be present at any time. So these things can be displayed either in the clinic or it can be part of the immunization card. So the parents will know how that they should be brought early at this particular. If the child is 18 months, the mother should know that these are the milestones that the child should have depending on the different domains, and so that the child can be brought early and rehabilitation can be started early. Now there is formal screening. This requires training. This also requires a standard tool to be used. So there are some very simple tools which even a field worker can use. I know that there are some non-medical people also who are here. For them, these kind of tools will be very useful. So these majority of my presentation is I've used the data from the Child Developmental Center in Trivandrum, where I had been trained for my degree. So this developmental observation card is a very simple card which can be used by the field workers itself. It only highlights 4 major milestones. That is, a child should achieve a social smile by 2 months, should hold the head by 4 months, should be able to sit without support by 8 months, and should be standing without support at 12 months. So these are the 4 major milestones that the parent has to remember. In addition, the parents should make sure that a child can see, hear and listen. So seeing, we know that the child will respond to the parents. Hearing is just responding to any noise, whereas listening is turning to the direction. That also shows that the child has got good cognition. So these things are, it's a very simple chart, and it has been found to pick up developmental delays to a significant number. The other kind of screening chart that we use is called as the CDC grading for motor milestones. So what is the CDC grading? This is again the Child Developmental Center grading for 3 of the major motor milestones, namely head holding, sitting and standing. So these milestones, you should know, are acquired over time. The child does not acquire head holding over 2 or 3 days. Okay, it takes a few weeks for the child to acquire the milestone. So each milestone occurs in different phases. So by the time a child is able to completely attain the head control at 4 months, there are so many little stages that take place. So we have to know whether the child is in grade 0 or grade 5 to tell whether the child is delayed or not. So by doing this grading, what happens is it is an objective way of doing the grading. So everybody will have the same opinion about the developmental status of the child, and whether the child has moved from grade 0 to grade 5 will tell us whether there is any improvement by doing your physiotherapy. And you can also tell the mother that because the child has moved from one grade to the other, the child has improved in his because of the rehabilitation. So these are the 5 grades. For head control, it is just the child being kept at the shoulder. You have minimal head control. Here, picking up the child from the bed, you will find the child's head coming along with the body, which is grade 2. This is in the prone position. The child lifts up the head from the table. The child has almost complete head control, but still there is some wobbling. Grade 5 is when the head control is complete. Similarly, for sitting, the child can be made to sit but cannot sit on his own. Here the child can sit but requires the support of the arms. Here the child sits with the back straight. The child manipulates the toy. Here the child gets up from the lying down position. These 3 grades will show that the child is normal. If the child at the end of 8 months is in either grade 1 or grade 2, that means this child is delayed. Same for standing. You make the child stand next to a stool, he stands. You make the child walk, he walks with hands held. Here the child is able to stand with his legs apart. He is able to get up from the lying down sitting position, and he walks on his own. Here again 3, 4 and 5 at 12 months means that the child is normally developing, whereas 1 and 2 means the child is still delayed. So at that particular age, if you see grade 0, 1 and 2 means that the child is delayed. 3, 4 and 5 means the child is normal. So why I told you earlier that this developmental screening is not a one-time event. You can't do a screening at 4 months. Okay, the head control has come, this child is normal. We can't do that because we know that the brain is continuously growing, and more so during the first 2 years of life. So we have to keep repeating the developmental screening every time the child comes to us. So for that reason, these developmental screening tools should be very simple. They should take very little time, and it should require very little training, and it should also require very minimal tools to conduct the screening. So this will tell us, by doing it at multiple points, you will be able to document the child's progress over time. So these are some of the developmental screening tools which are used in the different development clinics. In our clinic, we use Denver 2 as well as Trivandrum Development Screening Chart, which was published in the year 2013. So these are the 2 tools that we use, and for both these trainings, Denver 2 requires tools, but whereas TDSC requires only very minimal training, and it has been found to have a sensitivity specificity in the range of 82% and 94%, and this is very good at picking up developmental delays among children. And there are 2 charts, one is from 0 to 3 years and the other one is from 3 to 6 years. So the number of the items that are required are also very minimal for a screening chart. You need blocks, we need a ball, we need pencil, a cup to put the blocks, raisins to show the pincer grasp, then you need a toy to show the parts of the toy, rattle or bell to check the hearing. So this is the Trivandrum Development Screening Chart for 0 to 3 years. How do we screen the child using this chart? So supposing this child is say 1 year old, you draw a line at 1 year. Okay, at 1 year a straight line is drawn, and all the milestones which are completely to the left of this line, that is completely to the left of this line, this child should have achieved. If the child has achieved all the milestones which are completely to the left of this particular age line, then this child is supposed to be normal. So this is 0 to 3 years. We have another chart for children between 3 to 6 years. Here again, supposing this child is about say say 45 months. Here again you draw a line at this particular age, and then you see all the milestones which are completely to the left. This is very easy to administer and doesn't take more than 5 minutes, does not need too much of cooperation of the child, and these are now forming part of the immunization card. So even the mothers, if they are fairly educated, they can be taught to look whether the child is delayed or not, and it is very easy to even train the field workers in administering this tool. The same thing for language, we have again from the CDC Trivandrum, and this one is the 0 to 3 years chart, where again you can use the same system of drawing a line at that particular age of the child and all the milestones which are completely to the left. It is important to do a language evaluation every time, because hearing should be picked up, hearing loss should be picked up as early as 3 to 6 months if the child has to have an intact speech and language function. Any delay beyond this age will result in a considerable reduction in the speech of the child as well as in the academic performance. So by doing an early language assessment, we can pick up, if the hearing loss has not been picked up earlier, at least by doing this we can pick it up little earlier than what would have happened if the child has been waiting up to school age. This is the chart that we follow in our clinic, which is called the Denver 2. Earlier it used to be called as the DDST. Now it is called as the Denver 2 chart. Here 4 domains are examined: the gross motor, language, fine motor and social. This requires a little kit, and we put together, although we did not get the original kit, we have put together the various toys which are required to administer this kit. This takes around 10 minutes to administer, and each item is divided into 2 parts. There's a white part and this is a gray or a colored part. So if a child's age line passes through this gray part and the child has not achieved the milestone, then we say that the child is having a caution and has to be evaluated for, or at least followed up for delay. Whereas if the age line is passing beyond the item and the child has not achieved the milestone, then we call it a delay. Now, since most of the pediatricians do not have time to do the screening tests themselves, now the onus is on the parents. So these questionnaires are given to the parents, and the parents fill up the answers to the questions, and they bring it either when they are coming for the immunization, or in the West it's even being done online. So this 10 question screen is one parent based questionnaire which is being followed in India. It has got a very high sensitivity and specificity, and it has picked up majority of the severe developmental disabilities, if not mild ones. Ages and stages questionnaire or parents evaluation of developmental status are those screens which are used in the West. Even in India, we also use a screening test called as modified checklist for autism in toddlers, and any time between 18 months to 30 months this can be used as a screening chart for picking up autism. So I'll quickly go through the questions of this 10 question screen, where by using this we can pick up majority of the developmental disabilities. Here we ask the parents, if compared to the other children, whether this child has a problem in sitting, standing or walking, whether the child has difficulties in seeing either in daytime, whether the child has difficulty in hearing, does the child have difficulty in walking or moving his or her arms, or is there weakness of stiffness in the arms, whether the child understands what you're saying, whether the child develops fits or loses consciousness, does the child learn to do things like the other children of their age, does the child speak at all, or is the child, whatever the child speaks, is it understood? Is it being understood? If the child's speech is different from the other children, whether it is clear, whether there is any kind of echolalia, those are the things that we have to ask regarding speech, and try to find out whether the child appears to be verbally backward, dull or slow. So these 10 questions will pick up majority of the developmental disabilities in the form of cerebral palsy, seizure disorders, visual problems, hearing problems, learning disabilities. So majority of the developmental disabilities can be picked up by this 10 question screen. So now that I have picked up a developmental delay, I have done a screening test. I have found out that this child, at the end of a screening test, we cannot say that the child definitely has a developmental disability. We can only say that there is a suspicion of developmental disability or developmental delay. Then subsequently this child has to be referred for developmental evaluations. So who will do it? The person has to be a trained person. So this person can be a developmental pediatrician or anybody who is trained in developmental pediatrics. So why do some babies have disabilities? So we know that these disabilities can start off in the period of pregnancy itself with any factor affecting the embryogenesis or in the fetal development. In that case, the baby will be abnormal at birth itself. But if the baby happens to be normal at birth, but there are perinatal problems and postnatal problems, then although the baby may appear to be normal at birth, these babies will present with a deficit a little later. So how do I go about a case of developmental disability? How do I confirm whether there is a disability, and how do I find out what is the reason for the disability? So why should I find out the reason for disability? Because I would like to know whether this child has got a treatable condition. I would like to know whether the child will improve with time or deteriorate with time. I have to involve the parents, tell them regarding the rehabilitation. I have to tell the parents whether there is a chance of this condition occurring in the subsequent pregnancy. So for all this reason, I have to establish the diagnosis in every case of developmental disability. So I will first try and find out whether the child had any risk factor either in the antenatal period or in the neonatal period, or subsequently find out if there are any risk factors which have resulted in the disability. And I would also take into consideration maternal concerns. Even if there are no risk factors, I would like to find out, because there are parents who will come and tell me that my child is not listening when I talk to her. So then we go ahead, check the hearing. Even if the hearing is normal, we have to go ahead and see if the child has any features of autism spectrum disorder. So after I have done a history evaluation for risk factors, then I go ahead and take a developmental history. Here I try to find out at what age the child achieved the various milestones, try and find out whether the child is following a normal course or whether there is a delay, and if she has other children, I will ask her whether the child is the same as the other children or there is any delay. And I also like to ask specific questions like, is the baby having any abnormal movements in the form of seizures or tremulousness? Then family history in cases of developmental delays or disabilities are very, very important, because we know that there are certain conditions which run in families. So I would like to know that there is a consanguineous marriage, whether there were any fetal losses, stillbirths, whether any other sibling has got a similar disability. And that will help me to find out whether this is the same condition or whether it's a new condition, or if it is a first child, whether it's going to occur in subsequent pregnancies. Then I'd like to know the fetal movements. If the child's movements are less, probably it's a hypotonic disorder. Whether the mother had any infections which can cause a so when I'm saying infections, we have to think in terms of HIV also. Whether the baby has when the mother was pregnant, whether the baby had been exposed to maternal drugs like alcohol or drugs or any anticonvulsants, whether the mother had any antenatal care at all, or she was one of those people who did not opt for antenatal care. Then birth history, I would like to know the history of asphyxia, prematurity, where the delivery was, because I would like to know that it's an institutional delivery, whether deliveries were conducted at home, who conducted the delivery, whether there was any chance of sepsis, things like that I would know from the birth history. During the neonatal period, I would like to think of all those conditions which would have an impact on the brain: apnea causing hypoxia, jaundice affecting the brain, poor feeding resulting in hypoglycemia, sepsis, meningitis, whether the child had been ventilated. Ventilation of more than 5 days itself is a risk factor for developmental delays. Then in addition, I would like to know whether the mother, what is her education, whether she is going through any psychological problems, because it not only affects the baby, it will also affect the care of the mother. It will care given by the mother. The mother should have an optimum mental status to first of all accept the fact that the child is having a delay and to involve the child in rehabilitation. It is generally mostly a mother's concern, and it's a mother's job to take care of the child after the hospital has done its job. Then find out whether any chronic like malnutrition and frequent hospitalizations will cause transient developmental delays. Both of them will recover completely once the primary condition is treated. Then whether there was any accident or trauma to the brain which has affected which has caused a delay. Now a few words about how the HIV as such affects the developing brain. So before the starting of this antiretroviral therapy in 1996, it was found that the HIV accounted for, 30 to 50% of the progressive encephalopathy was seen in these people who had HIV infection, and it accounted for 90% of the static encephalopathy. But after the beginning of the heart therapy, we found that the incidence of progressive encephalopathy has come down to 5 to 10%. So this is from the human resource on HIV. That is the data. This is the data I got from that. And why? And this is because of the early treatment, starting from the maternal treatment, and also we are doing clinical monitoring continuously, and we have found that this has resulted in the symptoms being identified early and therefore being less severe. So the brain infection by HIV is active, and it is the primary infection, and this is persistent and occurs soon after birth. And in those children with perinatal infection, you can find the clinical signs of dysfunction as early as 2 months of age, and sometimes even up to 5 years we may not pick up the dysfunction. So what are the things that you find in children who are having HIV infection? The neurological problems will be in the form of developmental delay or loss of previously acquired milestones. Child will have a cerebral atrophy resulting in microcephaly or deceleration in head growth. Because the white matter is predominantly affected, the child will have an abnormal tone with increased reflexes. Sometimes specific parts of the brain may be affected, resulting in focal neurological deficit, and speech and language delay is considerably an association of a child who has HIV infection. So this is a study which is published in 2013 showing the different neurological associations with HIV, and you see that language impairment is commonly seen in these children, and among the neuroimaging also you will find that white matter lesions are predominantly seen, and widening of the ventricles is also seen. So these are some of the neuroimaging findings that have been published in children with HIV. So how do we follow up these children with HIV? You should do besides doing a neurological evaluation or a neurodevelopmental follow-up, ophthalmological evaluation including a yearly retinal examination should be performed in all these children, because they are at a significant risk for ocular infections like CMV, retinitis, toxoplasmosis and herpes infection. And subsequent neurological follow-up will be determined by how severe the neurological involvement was at the time of assessment and whether any new neurological symptoms have appeared. Now going on to examination of a child with disability, we do have to do a top to toe examination. We do a neurological examination, look for the presence of seizures, look for the presence of spontaneous symmetrical movements of the child. We do a developmental assessment by finding out whether the child is keeping up with the developmental milestones, whether there are any abnormal reflexes which are persistently remaining even after the time of disappearance. Then in the head, we should not forget to measure the head circumference every time the child comes for a follow-up, and it is not enough if we just measure the circumference, it should be plotted on the CDC charts. So for growth, we follow the CDC charts up to 5 years, and here we CDC, it's a WHO chart rather, WHO chart for growth for weight, length and head circumference. Special charts are available for boys and girls. It has to be plotted on the chart, and we have to see whether they follow the same line of growth. See the fontanelles, whether they are open till the time that they should be open and whether they close at the appropriate time. The sutures, whether they are wide apart or whether they are fusion very early. Plot the length and weight. As I told you, nutrition is very important in a child's development and the brain growth. So if there is any problem with the length and the weight also, that can affect the baby's development. Look at the eyes, face, hands, feet. Try to find out whether there are any symptoms which fit into any particular syndrome. So eyes are very important. Besides that, look at the skin, abdomen, genitalia, and don't forget to look at the neck and the back. Several findings can be missed if you don't spend a few seconds looking at the back. So these are charts which I have got from the net, and some of them are my own patients, but some of them are pictures which I have downloaded from the net. And head size, always try to find out whether the child fits into the macrocephalic group or microcephalic group. Microcephaly, we know that if it is -3 standard deviations in the growth chart, then it is called microcephaly. Look at the fontanelles, abnormally large or absent or small. This is one of our ventilated children who had who was ventilated for asphyxia. Subsequently, there is a microcephaly, and this is the overriding of sutures because the skull is growing much more than the underlying brain. This is also one of our patients having a very delayed head control. So because a baby is spending lot of time in the supine position, this child has got hair loss at the back of the head. So these are some things that we have to look at when you're examining a child. So here you have this child who at 8 months has got persistent fisting of the hands. So this again is a feature of white matter degeneration, and also it is a sign that this child is neurologically abnormal. In addition to that, we also have to look for malformations in the other systems, whether there is a meningomyelocele or an encephalocele, whether there is a gastroschisis. Look at the genitals. So what happens is, some things if you do not examine you will miss, like looking at the anal opening or looking for spina bifida, but some things may be internal and so we may miss it, and that is like cardiac, renal. If you find that a child is having a persistent delay in development where you are not able to pick up other causes, kindly do an echo or an X-ray at least to find out whether there are any underlying problems. But see whether the child fits into any kind of a syndrome. Why do we need to do that? We need to know whether this particular child is the index case and whether subsequent deliveries are also going to result in children with trisomy. So whenever a child comes with any kind of dysmorphism like this, it is worth getting a genetic opinion and even doing a karyotyping, so that once you establish the etiology in these children, then subsequently we can prognosticate to the mother about the future of this child and whether the subsequent pregnancy will be affected. Eyes are very, very important, and always take a few extra minutes to open a newborn's eyes to see whether there is any cataract or white pupils, whether the child's eyes are developed normally or not. Look for associated abnormalities around the ears, which will tell us whether it can affect hearing or not. Skin is another indicator. Look around, strip the child completely and look for neurocutaneous markers, which sometimes in a dark skin may not be picked up easily. And then spina bifida. This is another thing which is missed very commonly. Okay. So there are some intra-uterine infections which will present with what symptom complex. Okay, so you can have skin findings, you can have eye findings, you can have cardiac problems, you can have hepatosplenomegaly, and when they all occur at a cluster, we know that they fit into some particular group. Then it becomes easy for us to investigate those children and come up with a diagnosis. Now coming to neurological examination, we all know that it usually follows the same proforma. We start with higher functions where we see whether the child is able to interact with you, whether his behavior is normal, whether the child is alert. Then we look at the cranial nerve, see whether the eyes are normal and whether the eye movements are normal, whether the child's face is having any asymmetry when the child cries. It's very important to ask for the history of feeding, especially in a newborn baby, because if the baby's feeding is abnormal, then it can give you a lot of information about the higher functions as well as the lower cranial nerves. And if the child's cry is hoarse, then again we will know that the 9th and 10th nerve may be having a problem. So always look for the vision. In vision, always depending on the age, we have charts, and we know that a 3-month-old child should be able to follow an object 180 degrees, that is from one end to the other. So looking at those simple charts, we have to do vision checking at different ages, and when we are not sure, It's always best to get an ophthalmologist opinion. Hearing, as I told you earlier, it should be screened in the newborn period itself. So how do we do that? Clinically, of course, we make noise and make the baby respond, but that is a very crude way of checking hearing, because a child may be startling to noise, but he may not be able to listen to sounds. So we need to do a hearing screening, which is usually done either by an autoacoustic emission or by a behavioral observation audiometry, and whenever there is a doubt, this child should be subjected to BERA. Then tone. So look at the core, whether the baby is having hypotonia like in this baby, or when you pull the baby, whether the whole baby comes up en masse like as in hypertonia. Look at the baby's movements against gravity, the deep tendon reflexes in a newborn. Even if it is brisk, it's okay, but reflexes should not be absent. And primitive reflexes, we know that these have to disappear so that milestones can be achieved. And so there are some reflexes which will disappear within 6 weeks, but latest by 9 months, some of the reflexes which will remain up to 9 months, they will disappear. Only then the next milestone will be achieved. So for hypotonia, we do the Hamilton passive angles, and here we pick up, this is a sign of hypertonia, where when on pulling up the baby, the entire baby comes up like a log, and this is hypotonia, where the baby is like a rag doll. You try to pull him up and his head is hanging behind. These you have specified angles. Hamilton angles has specified standardized angles which are established up to 1 year of age. So here we do an adductor angle. By separating the legs, you find out the angle in between, and the lesser these angles, the more likely this child is going in for an adductor spasm, or it's an early sign of cerebral palsy. Here you try to flex the baby's thighs over the abdomen, and you see the angle between the back of the thighs and the bed. This is called the heel to ear angle. Here popliteal angle, where the legs are extended by the side of the abdomen, you see the popliteal angle, and the tighter the popliteal angle, there again you know that the baby is going to go, is probably an early sign of cerebral palsy or any hypertonic disorder. Then this flexion of the foot over the legs. So if this is difficult to achieve, then we know that this child is probably having a periventricular leukomalacia. This is an early sign in case of a preterm baby to pick up hypertonia. And this is the scarf sign, where you try to pull the child's arm across the midline, and if it is difficult, we know that there is an increased tone in the upper limbs. These are again charts which I have obtained from CDC Trivandrum. These are some of the primitive reflexes. All these reflexes have to disappear at the age at which they are supposed to. If they do not do that, then we know that the subsequent milestone will not be achieved. Like palmar grasp, if it is present beyond 6 months, then we know this child will never open his hands and reach out for objects. Now that we have done a thorough head to foot examination after getting the history, we know that this child has a developmental disorder or a medical problem leading on to a developmental delay. So if it is a medical problem, the child should be sent to a pediatrician or a physician to treat the condition, probably a hypothyroidism or severe malnutrition or a cardiac problem. But if that is not there, you think that this is purely a developmental disorder, then you send the child for a developmental assessment to find out what is a developmental quotient. So up to 3 years we call it a developmental quotient, where the developmental age divided by the chronological age will give you the developmental quotient of the child. Beyond 3 years we do the intelligence quotient or the IQ testing. So for doing the developmental assessment, we have 3 scales. One is the Darcy, which is our Indianized version of the Bailey scale. It's called the Developmental Assessment Scale for Indian Infants. And BSID is the Bailey scale of infant development. The latest version is 3. And then Griffith scales. All the BSID is constant training is being done by Pearson, who is in charge of the kit. The problem with these developmental assessment kits is that they require formal training. While Bailey's training is for a day, Darcy training provided by KEM Pune is for 6 days. So and in addition to that, these kits are expensive, and each assessment takes about 45 minutes to 1 hour. So we probably appointments should be given in such a way that you find that the child is in a comfortable mood, having had his food, and you allot this much time so that you don't compromise on the ultimate quotient. So I'm sorry for this. This should read as Darcy. This is the kit of Darcy. So now that you know that the child is having a developmental delay, what investigation should we do to confirm the diagnosis? The first and the most important thing that I have to tell you, that we have to be selective, because there are a whole gamut of investigations which are available, and even if you do all of them, in some cases you may not even able to arrive at the diagnosis. So for this reason, and because majority of these investigations are expensive, always be selective and rational in choosing your investigations. At the end of your history and physical examination, you should be able to come to some kind of a diagnosis regarding the subtype of the developmental delay. So what investigations are absolutely mandatory will be a thyroid profile, and in most cases a neuroimaging. Whenever the child has seizures, one would have to do an EEG to find out the type of seizure, or any abnormal movement, you do an EEG to confirm whether that it is a seizure or not. And sorry, metabolic screening. For whom do we do metabolic screening? Whenever there is a fetal loss, when there is a consanguinity, when there is a sibling suffering from the severe similar illness, and also when this metabolic, when you find that the child's symptoms cannot be accounted for by other neurological conditions, always have inborn errors of metabolism in mind. So for whom do we do genetic studies? When you think this child's probably the dysmorphic facies fits into any particular syndrome, then we do the genetic studies. Recurrent seizures also is supposed to be due to some genetic problems, and even that is being taken care of by, we do genetic studies in those cases also. Having said all this, now we have come to the last part of our talk, what to do in case of developmental disability. So majority of the developmental disabilities do not have a cure. That is a sad part of it. But what we can do is we can rehabilitate these children to a significant extent and make them considerably much more worthwhile to the society than they would have been if nothing had been done for them. So we should remember that this dendritic growth and synaptogenesis, these things occur from 8 months to 2 years. Okay, so what happens is during this time you will have majority of the synapses being formed, and when it is not used, you will find that the synapses just get eliminated. Okay, and this selective pruning, so how does one decide whether these synapses are going to remain or not? That is influenced by environment and experience. So this maximum synaptic density will happen between 15 months and 2 to 3 years of age, and if we do not continue to use those synapses during that time, you will lose them for sure. So by the next 15 to 16 years, you will find that those synapses which have not been in use will be permanently lost. And if you see myelination also, you will find that there are 2 or 3 peaks in myelination. One is at 2 years, the other one is at 7 to 9 years, and the third is at 11 to 12 years. So how does a brain insult occur? So following a brain insult, what happens is the neural networks can get disrupted, the neurons can die, the axons may be damaged, the neurotransmitter systems may be affected, or the vasculature can be affected. So in any of these ways, a brain can get insulted. So how does a brain recover? 2 methods. One is restitution. In restitution, what happens? Whatever pathways were there earlier, they'll just get reactivated and functions will get restored. Or in most cases, what happens is there is substitution. That means if an area is subserving the visual function and it has been destroyed, you will find some other area taking over the function of that particular area, which is called substitution, and that can occur only majority within 3 years of life, when the brain is supposed to be plastic. It's called neuroplasticity of the brain. So we have to use this mechanism in our early stimulation. Make use of the existing normal brain and try to make the child perform as much function as possible to make the child a near normal human being. So when does the stimulation start? It starts in the NICU. It starts as soon as a child is born. We do not have to wait till the child comes out of the nursery or goes home. Even in the NICU, the mother can keep the child on the chest and the stimulation can start. Talking to the child, the touch that the mother provides to the child, all these will give the child adequate stimulation for new pathways to be formed. How does massage help? We know that the continuous touch by the mother is at the appropriate time, when the child is in an appropriate state of mind, is supposed to release endorphins. It's also supposed to release hormones which help the growth development. It also helps in the formation of new neural pathways. So massage has been, if it is done in the proper way, has been found to be highly beneficial to a child's neurodevelopment. In addition, for the visual stimulation, it is necessary for a child to be exposed to colorful toys, and the child at a distance that the child can see, and it does not have to be costly like this. It can be a simple toy. It can even be a little feather which is tied on the thread, or it can be a piece of ribbon which is tied to a thread which is fluttering in the breeze, and that can cause this child to focus on it and can cause an improvement in its visual function. These black and white patterns are the patterns which are preferred by a child. So instead of making flashcards like this, we normally advise chessboard pattern. So they can buy it even from the roadside shop and show it to the child at regular intervals, and this pattern is particularly supposed to stimulate the visual stimulation. In addition, the mother can keep the child in the palm of the hand and look at the baby's face and talk to the child, which can start as early as 2 weeks of life. And you can find that by 3 to 4 weeks the child starts regarding the mother's face, and by 6 weeks the child will be smiling back at the mother when the mother smiles at the child. This is tactile stimulation, where this mat has got textures of different kinds. Some of them are soft, some of them are rough. All this will help to stimulate the tactile sensations of the baby. Then oromotor stimulation, we know it is very important. Anything that a child gets, he first prefers to put it in the mouth, because that's the way the child assesses the shape, the size and the texture of a particular toy. So oromotor stimulation is very important, and it starts around 6 months of age, when the child is able to reach for a toy and takes it to the mouth. So only thing we have to see that these toys are very clean and they are non-toxic. Unlike certain lead paints which can result in toxicity to the child. Even a single finger brush that is available in the baby shops, if we use it to clean stimulate the gums of a child or the cheeks of the child, which is of great help in children with cerebral palsy to establish new neural pathways from the mouth to the brain. In vestibular stimulation, these children, it's very, very helpful. The rocking movements or the cradle which the ancestors had developed for us is very useful. Again, here we do not require such a costly equipment. Anything which produces the rocking movement is supposed to help the vestibular stimulation of the baby. Hearing stimulation, again, child should be exposed to simple sounds and not jazz music or loud music. Simple rattle or bell will stimulate the baby's hearing, and the child can be exposed to any soft music, which even in a NICU soft music can be played, so that stimulates the hearing of a child. For fine motor stimulation, the child can be given little toys and little blocks or a ball, and even the Play-Doh which is available in the toy shops, those are non-toxic, that can be help to improve the fine motor of the child. And even the chapati dough that is used, that also can be given, which improves the strength of the muscles of the hands. Then these are again charts which I have got from the book on early stimulation by Dr. M.K.C. Nair, and here these are little interventions which will help to promote the head control. The child can be put on the tummy. This is called the tummy time, about 1.5 hours after a feed, and when the child lifts up the head, the child's neck muscles develop control. So by holding the child on the mother's lap or with the legs stretched outright, you can improve the neck muscle strength. That's what we attempt to do for head control. In addition, the baby can either be put on a small bolster where the child again lifts up the head and improves the head control. Child is kept astride on the mother's lap. Here again he is lifting up the head. Then if a toy is thrown at a little distance, the child, when trying to get the toy, tries to lift up the head, and in this position also the child is balancing his head on the trunk. To promote rolling, this is a very difficult step, and this requires a lot of coordination, by which time the head control should have been achieved, and this child's legs are flexed on the abdomen, slowly turned to one side, and then the hand which is underneath the baby's head is removed, and slowly the child rolls over. In a little or the child can also be placed close to a toy, but just out of reach of the toy, so that the child rolls over to try and get the toy, or if the child, a mirror is kept, the child tries to reach the mirror to look at himself. For sitting, there are two ways. One, to make the child lie on a side and just lift up the hand which is above. This hand which is below, supporting the baby's body, pushes this child above, and the child learns to sit. Here, the kneeling position, make the child kneel down and then come to the sitting position. So you don't have to wait for a physiotherapist to start. That's why I'm telling this in the clinical discussion itself. Every time we cannot be dependent on a physiotherapist, or the parents may not have access to a physiotherapist, or they may think that paying for a physiotherapist is beyond their needs. So what we can do is just teach them little exercises. Before a child leaves your clinic, the child should have started his way to rehabilitation. Depending on which stage the child is, even if the child is normal, you can tell the mother to do simple exercises to promote stimulation and to make sure that the development is progressing in the normal pattern. So these are steps: holding the child with your hands, making the child walk, or using these rails also to promote the child's walking. For fine motor, as I told you earlier, we can either give the smiley balls, see that the child, if it is a fisted child, see that the child is opening out all his fingers on the surface of a table or a mat, and then open out the fingers so that you prevent contractures and permanent fisting. And on this note, I stop. We pick up developmental delays or disabilities. Our job is in making the child as nearly normal as possible, and that is very much possible if the child is put on the right path to rehabilitation. Thank you.
Thank you so much, ma'am. It was
Hello.
Thank you so much, ma'am. It was indeed a nice presentation. Now I request all of the participants, if they have any question, they can write it down on their chat box. You can see the chat box on their right side. Please ask any question if you have. On your left side, you can see e-poll. Please vote on this e-poll. The recorded link and the presentation will be circulated to you shortly. Thank you so much, dear participant, to attend the NDLS series. Thank you so much, ma'am. Thank you all.